Welcome back. New York City, we're doing an injection suture suspension facelift. We just walked through the use of injectable RF quantum style with Morpheus. Now we're adding injectable soft tissue filler, and we're going to do volumization of the infraorbital, high zygomatic, and parasymphyseal buttresses. And so the technique for injection in my hands is always going to be like fat grafting. Zoom in on this if you can, Carlos. I'm going to be using a micro cannula. So if we look at the tips of these products right here, there's a blunt tip micro cannula, single port, and a sharp introduction instrument that's shaped like a spear. This is more likely to get into a facial artery, transverse facial or facial artery, than perhaps a blunt instrument. But a blunt instrument used forcefully can also get into an embolic vessel. So I would take an ultrasound, map out the vascular anatomy of the face, know where the big arteries are and avoid them. If you've been doing injectables a long time, you know where they are and avoid them. But I always do blunt microcannula because I think it's faster in my hands. I get less bruising and probably less likely to get in a facial vessel than a sharp needle. But I still need to get under the skin with this. And so let's come back to our patient, and we're going to be injecting, in this case, an HA gel. Which HA gel? It could be Restylane, it could be Juvederm, it could be Toxin, it could be Prolenium. Any one of the 4 big gel companies in the US, they're all good. They all have a little lidocaine. They all last 9 months to a year, especially in non-animated areas. So work with a company that gives you the best price. And so there's 1 syringe of the Prolenium product. I'm using this because I'm a very patriotic ex-Canadian resident, and it's a Canadian company. It's actually the only filler made in North America. The only filler made in North America with good old GMP processes, and it does very well. It lasts, gives you volume, gives you support, it's lubricious, it injects down a cannula well. Just make sure you get the best possible price per syringe, which translates into more profit. Let's turn this way, and let's just do the high zygomatic arch first and the infraorbital buttress second. Not much here, canthus to canthus. I'm going to be down under orbicularis oculi, on top of the septum. Don't go superficial under the eye, or you get what's called the Tyndall effect, which is how light is absorbed and reflected when it's an HA gel. You get that bluish discoloration. So stay deep under the eye and deep on top of the bone, up the cheekbone. Now, how am I going to get there? I take my port creator, I come down the nasojugular groove, orbital malar groove, and I come just about the malar eminence region, and I pop under the skin. That will allow me, with a 22 gauge, 2-inch micro cannula, I use Dermasculpt, to go up the high zygomatic border to open up her zygoma slightly. Remember, bizygomatic width looks more attractive, not too much. Turn and come right up her orbital malar groove, nasojugular groove, and go from canthus to canthus. Nothing in the malar eminence. That looks good on her. We don't need that. And so we'll start by doing the infraorbital buttress first. I go through the same port that I just created, and that's sometimes the toughest part of the procedure. I go right down to the bone, so I'm right on the bone of the malar eminence. I'm going to park my sharp needle, and now I do a little anterograde advancement and then retrograde injection. Now I'm under orbicularis oculi, right above the orbital septum, above the orbital rim. I'm going to lay down little toothpicks across to the lateral canthus and back again. So advance, inject. Low pressure, small aliquot. Advance, inject. Advance, inject. You could pull back a bit each time to see if there's a squirt of blood, but there never will be at this level. But it's a good technique to get into. You did some vascular mapping with your ultrasound. So I do a little squirt, little squirt, little squirt, retrograde each time, all across like a little teepee, a little lean-to from the orbital rim up to the tarsal plate, right to the lateral canthus and back again. Chin down a bit there. Same thing back again. Advance, inject, advance, inject, advance, inject, advance, inject. On the way back, deep under orbicularis oculi. And what does that look like? So stay down the nasojugular groove, so about 0.4 cc's from canthus to canthus. And this is what it looks like. If I advance and inject on the way back, I lay down a little toothpick like that. Advance, inject, a little toothpick. And then another little toothpick. Each one lives in its own little home. Zoom in on that if you can, Ricardo. Each one of these lives in its little home. It ain't going to migrate because it does this. I advance, soft tissue opens up. I inject on the way back, it closes on it. Then another one, then another one, then another one. I don't like big depot deposition because you drag bacteria in small amounts and you can get an inflammatory nodule some months later, especially with certain formulations of HA gel. So I love these little independent aliquots or toothpicks. Now, she's got a bit of an orbital malar groove, so I'm going to come down to the malar eminence and use about a half cc in that infraorbital groove. Not much, just a bit. Nothing in the malar eminence. And there's 1 cc to treat this entire area. Now I'm going to go up the zygomatic arch with a 1 cc volume up the zygomatic arch to create a little bit of lateral zygomatic volume because she's got a nice big malar eminence. I'm going to stay high to increase and open up that oval look, the oval look of youth. So stay on top of zygomaticus major monorum, just above the bone, retrograde toothpicking, and build up deeply a little zygomatic augmentation. Maybe on her, even half a cc is going to be enough, not too much. There's half a cc up that zygomatic arch. So malar is nice, zygomatic augmentation, infraorbital augmentation.